Welcome to this lecture on the Cost Effectiveness Index for healthcare providers using claims data. I'm Dennis Arundel, a data-driven health economist with more than 10 years of experience in this field. Today, we'll delve into a comprehensive framework to compare healthcare providers based on their relative cost effectiveness using claims data. This is a crucial aspect of health economics, as it enables us to make informed decisions that can improve patient care while managing costs effectively. Our goal is to explore how to develop a robust cost effectiveness index that accounts for various factors, ultimately leading to more precise evaluations and better healthcare outcomes. Let's begin by discussing a common yet fundamentally flawed method of comparing healthcare providers. Often, providers are evaluated using a single parameter, such as the total cost of prescribed medicine. While this might seem straightforward, it is overly simplistic and can lead to misleading conclusions. For example, a general practitioner, GP, who prescribes more expensive medications might appear less cost effective, even if those medications lead to better long-term outcomes for patients. This approach fails to capture the complexity of healthcare delivery and the multi-factor nature of cost effectiveness. In practice, when confronted with high costs by, for example, the insurer, physicians often have justifications. They might say, "It's not what it looks like. I can explain. It is true that I prescribe a lot of pharmaceuticals, but that is only because I have a lot of patients that are A, old, B, poor and uneducated, C, chronically sick." Or they might argue things such as, "My laboratory and radiology requests are high so that I can catch diseases earlier, thereby preventing hospital admissions." Or other statements such as, "Yes, I do more consultations than my peers, but this also leads to lower referrals to medical specialists, thereby saving total costs for the insurance company." These explanations underscore the need for a more nuanced approach that considers multiple factors influencing costs and outcomes. By understanding and addressing these justifications in advance, we take the complexity of healthcare provision into account and thereby better equip ourselves to make data-driven decisions in healthcare. This brings us to the focus of our lecture, the Cost Effectiveness Index. This index provides a comprehensive framework by incorporating various factors into the analysis. We'll categorize variables into three groups based on Donabedian's model. These are structure, process, and outcome. This model helps us understand not just what healthcare providers are doing, but also the context and results of their actions. It enables a balanced assessment, taking into account the resources, activities, and results associated with healthcare delivery. First, let's examine the structure variables, which provide the context in which healthcare is provided. These include total population size. This gives us a sense of the scale of the practice. Percentage population aged 50 plus. Older populations generally require more healthcare services. We select the age of 50 plus as a simple yes or no cutoff point to get an indication of how old the patient population of a particular GP is. Percentage of population with low economic status, SES. SES can influence healthcare outcomes and healthcare utilizations. In many insurance systems, you can identify low SES patients because their healthcare reimbursement may come from a very specific source, such as a government aid program. Or they might have special rights to certain healthcare products or receive discounts on premium payments. Therefore, In many claims datasets, you can somewhat identify the patient segment that is labeled as low socioeconomic status. Percentage of population with diabetes. This is measured by checking which patients are consumers of any pharmaceutical product that starts with ATC code A10. Information about the ATC codes can usually be obtained from pharmaceutical claims data. Chronic conditions like diabetes significantly impact healthcare costs. The prevalence of such conditions can indicate the complexity of care needed in a population. By understanding these structural factors, we can better interpret the data on healthcare provider context and performance. These factors provide a baseline context that helps us adjust our evaluations to be fair and comprehensive. In the literature, this procedure is sometimes also referred to as risk stratification. Next, we look at the process variables, which describe the actions by healthcare providers. These include prescribed drugs per capita. The total cost of medications prescribed by the GP is divided by the total population size to get a per capita amount. Consultation costs per capita. Frequent consultations might indicate thorough care, but also higher costs. Laboratory request cost per capita. Lab tests are essential for diagnosis and monitoring, but can contribute significantly to cost. Radiology request costs per capita. Imaging is another critical diagnostic tool that needs to be balanced against its cost. Referrals to medical specialists per capita. This variable contains the frequency of referring patients to specialists. High referral rates might indicate good management of complex cases or an over-reliance on specialists. These variables help us understand the specific actions that drive costs and potentially influence patient outcomes. They provide insights into the operational aspects of healthcare delivery, shedding light on where the efficiencies or inefficiencies might lie. The outcome variable we'll focus on is hospital admission costs per capita. This is a crucial indicator of healthcare outcomes, as hospital admissions are often costly and can reflect the effectiveness of outpatient care. High hospital admissions might indicate poor management of chronic conditions or delayed diagnoses. By including outcome variables, we ensure that our analysis captures the end result of healthcare processes, which are ultimately the most critical measures of effectiveness. Using aggregated claims data per general practitioner, GP, we create a tidy dataset. This dataset adjusts for differences in GP practices by expressing all values per capita, thus leveling the playing field. For instance, rather than comparing raw drug costs, we compare drug cost per patient registered at that provider for that year. This ensures that large GP practices don't appear disproportionately more costly simply due to their size. This per capita calculation allows us to make fair comparisons across diverse practices. Here is a zoomed-in version of the first few parameters used in our dataset. And over here, you can see the demographic variables for each GP. All right. So now that we have an overview of all the different types of data that is available for the GPs, we can get to the key insight.
If you're interested in learning more in-depth information about healthcare claims data, then you should definitely check out my online course about data science for healthcare claims data. This course contains hours of lectures covering both theoretical knowledge as well as hands-on practical activities. Click on the link in the description of this video to access this course.
All right. So now that we have an overview of all the different types of data that is available for the GPs, we can get to the key insight. The key insight here is that we can reduce all dimensions to two primary variables. The risk profile, this captures the patient demographics and health status, and the cost profile. This captures the various costs associated with patient care. Optionally, we can consider hospital admissions as a third variable representing outcome. By simplifying our analysis to these core profiles, we can more easily interpret the data and draw meaningful conclusions. Let's define the risk and cost profiles. The risk profile variable includes percentage of population aged 50 plus, percentage of population that is of low socioeconomic status, and the percentage of the population that has diabetes. These factors help us understand the inherent risks and challenges faced by each GP. Higher percentages indicate a higher risk profile, which may necessitate more intensive or costly care. The cost profile variables capture the financial aspects of patient care. High cost might reflect necessary expenditures for quality care or potential inefficiencies that need addressing. When examining our dataset, we notice that the range of values varies significantly between different parameters. For instance, the prescribed drug cost per capita might be in the hundreds of dollars range for each GP, while the referrals to medical specialists per capita might range from 0.5 to 2.0. Both of these parameters are crucial, but a disparity in their scales makes it challenging to combine or compare them directly. To address this issue, we use a technique called standardization. Standardization transforms these variables so that they have a mean of 0 and a standard deviation of 1. This process involves subtracting the mean of each variable from its individual values and then dividing by the standard deviation. The result is that all variables are on a comparable scale, making it possible to add or subtract them meaningfully. This adjustment allows us to analyze the data more effectively and draw accurate conclusions about cost effectiveness. After standardization, our tidy dataset will have all numbers close to 0, in this case within a range of roughly -2 to 2. This transformation allows us to compare different variables on an equal footing. For example, a GP with a standardized drug cost of 1.5 is significantly above average, while one with a standardized referral rate of -0.5 is slightly below average. A GP with a score of approximately 0 is exactly at the average. Next, we calculate the average of risk profile and cost profile for each healthcare provider. This involves averaging the standardized value for each profile, creating two new columns in our dataset. For simplicity, we will ignore the hospital admission metric for now. These averages provide a summary measure of each GP's performance relative to their peers. So in the case of GP number 13, this GP has a higher than average risk profile, but their costs are slightly lower than the average cost. Now that we have two extra columns, we then create a scatter plot with on the x-axis the risk profile, and on the y-axis, the cost profile. This visualization helps identify providers with different costs and profiles, providing a clear picture of their relative cost effectiveness. In the scatter plot, you will find that the left side means lower than average risk, and the right side means higher than average risk. The lower side of the scatter plot means lower than average cost, and the higher side of the scatter plot means higher than average costs. Each dot represents a GP. This plot helps us quickly identify outliers and trends among providers. For example, a GP in the upper right quadrant has high costs and high risk patients, while one in the lower left quadrant has low cost and low risk patients. We can see that overall, as the risk profile increases, the cost profile increases as well. This is also what we expect. To intuitively interpret the scatter plot, we create a quadrant with a red zone, which means low risk profile and higher than average costs, indicating potentially least cost-effective providers. On the other hand, we have the green zone over here, indicating high risk profile and lower than average cost, which potentially means the most cost-effective providers. The other two zones are considered to be normal and in line with expectations. This visualization allows us to identify which GPs might require further investigation or intervention. GPs in the red zone may benefit from targeted cost management strategies, whilst those in the green zone can serve as models to be learned from to achieve more cost-effective practice. For a more detailed analysis, we can include hospital admissions as a third variable. This can be visualized using a 3D scatter plot or a bubble scatter plot, where the size of the bubble indicates hospital admissions. This additional dimension helps us to understand the impact of outpatient care on hospital utilization. In the 3D bubble scatter plot, we have the x-axis depicting the risk profile and the y-axis depicting the cost profile. The size of the bubble of each GP indicates their hospital admissions per capita, providing us with a third variable to analyze in the same scatter plot. This provides a holistic view of cost effectiveness, allowing us to see how risk, cost, and outcomes interact. Larger bubbles indicate higher hospital admissions, highlighting areas where outpatient care might be failing to prevent more costly inpatient care. This method provides us with a comprehensive tool to compare different healthcare providers using 2 or 3 simple dimensions. It is intuitive to follow and relatively straightforward to understand, making it accessible for both analysts and decision makers. By focusing on these key dimensions, we gain clear insights into the relative cost effectiveness of each provider. Using this comprehensive cost effectiveness index, we can objectively evaluate healthcare providers. This approach allows us to reach out to healthcare providers with very specific insights, such as, given the risk profile and health outcomes, this provider appears to be the least or most cost-effective. This method provides a balanced and fairly objective view, considering both the challenges faced by the providers and the costs they incur. It enables targeted interventions, supports evidence-based policy decisions, and ultimately leads to better healthcare outcomes. To solidify our understanding, let's practice with an example dataset in Microsoft Excel. By working through a real dataset, you'll gain hands-on experience in applying these concepts, from creating a tidy dataset to generating and interpreting scatter plots. This practical exercise will reinforce your learning and provide you with the tools needed to apply these methods in your own work. Are you ready? See you in the next lecture.
If you're interested in learning more in-depth information about healthcare claims data, then you should definitely check out my online course about data science for healthcare claims data. This course contains hours of lectures covering both theoretical knowledge as well as hands-on practical activities. Click on the link in the description of this video to access this course.